gave that it it that it amplified really had a profound impact on um, certainly my generation of medical students and public health practitioners, and I think, and it's a concept and a notion that continues to really resonate and give memorial to the extraordinary losses we continue to face with pandemics of multiple varieties, and certainly, um, as was mentioned, with the ongoing horrific toll of the COVID pandemic. Um, so that really this I think the global AIDS movement really motivated me. You can go to the next slide. Um, and to this was an image from many years ago, but to travel to Nepal and work in Nepal for a course of about 15 years following the civil war. This is an area called Acham in the far west that was the epicenter of the HIV pandemic, or the concentrated HIV epidemic among migrant workers, and the civil war with the Royal Nepal Army and the Maoist groups. And that that work over the course of years, somebody mentioned white saviorism. I think that much of my own journey in Nepal was a long journey of deconstructing various levels of saviorism, of whether it's white saviorism, American exceptionalism, physician, sort of dominant physician culture, the culture of experts in public health, that that was, in addition to the really human, empathetic idea of coming together as a global society to fight global injustices, was also a major part of the psychology of my own journey in public health. So I endeavored over the course of many years, and you can go to the next slide, in working in this community in Acham, and over the course of many years, developing with this extraordinary group of people, this work in rural hospital and community health care worker building, with in various attempts at close partnership with various levels of municipal, state, and federal government in Nepal, following the constitution, the new constitution of 2015, following the devastating 2015 earthquakes. There's a federal system of governance built in many ways off the Kenya constitution, that has 7 states, a central government, and 750 municipalities. And I would say the single biggest concept that I really learned through my work, and we had developed a few different organizations and different entities as a result of this, one being this group called Possible, one being Health Nepal. We've more recently developed an AMPATH Nepal partnership with Duikal Teaching Hospital, Kathmandu University, but all of those, I think I continue to be humbled by the ways in which power, as it's wielded, yes, between countries, yes, between different individuals with different positionalities, such as myself, a white male physician from America or from the United States, and also within institutions of how does a hospital that is built off a public hospital like this one that is built off of, that we really try to intentionally construct off of an idea of social justice, how does it become embedded in its own administrative structures, ways in which doctors are privileged castes are privileged, men are privileged, and even within our own processes for that are supposed to support workforce or support care seekers. How do those structures advance certain power interests versus health equity? So I'm going to, so now I actually wanted to just kind of give a little bit of an introduction of that work, and and depending upon people's interests, I'd love to hear my questions or commentary or what this evokes. But I want to first go to the next slide and actually talk about, I'm an internal medicine pediatric doctor, as mentioned, and I became a COVID doctor at Elmhurst Hospital, a public hospital in my neighborhood in Queens, and that really sort of forever, as COVID has for all of us, forever kind of shaped my worldview and shaped who I am, and just there continues to be just the trauma and horrors, particularly of that original surge where so many people died, and so many people died unnecessarily and in such horrible circumstances. But it's really, these few years of COVID has really kind of evoked even more reflection for me about the ways in which doctors and healthcare institutions wield power over care seekers. So I thought I'd tell, actually, this is sort of a amalgamated story from a person I met actually in September of this year, who got COVID during Omicron and was on a ventilator and paralyzed for 2 months, and got a series of horrible complications as a result of that. And I met him after he had been sort of blacklisted from multiple healthcare facilities and dialysis centers. He has kidney failure and requires dialysis, and really is, somebody who would be branded as a difficult patient, somebody who people would say, oh, he's going to leave against medical advice, which is a patronizing medical legal term that it really irks me, because we as clinicians do so much against patient preference, and this was really his story and his struggle of receiving care that just very infrequently actually met his needs and actually caused him harm. And then we would say, well, you're not with the program, you're not doing the physical therapy that we need you to do, you're not taking the medications in the way that we need you to do, you're not going to the right dialysis center, you're not going to the right nursing home. And we really have to ask ourselves, who are we trying to serve? Are we trying to serve the sort of our own sort of power and ego interests as caregivers, or are we trying to serve the care seeker? And this was, and this is at a public hospital. This is a hospital that we're trying to. We have a mandate to care for everybody and to really care without regards to insurance status, and we have a wonderful mission. And yet, I would say this person, who perhaps is unsurprisingly is happens also to be a lifelong New Yorker and a Black New Yorker, received highly racialized and disrespectful care at our own institution and multiple institutions across the city. So you can go to the next slide. So, I think that the big issue here that I just, is probably obvious for any of you who've been in received healthcare or had a family member, especially a vulnerable family member who's received healthcare, that we physicians really have a power issue. So I'm going to just pause there and see if this evokes any comments or questions, thoughts. All right, we can keep going. Please do interrupt or raise your hand or put a chat in. Oh, it looks like there might be a chat here. Oh, that's a beautiful question, Calvin. Thank you, Calvin Tran. So let me just read this. Is he difficult, or are physicians burned out? What is the limit to their empathy and threshold to providing care? How can physicians continue to reevaluate and reflect on internal biases to effectively and consciously provide good care? Is it lack of understanding and cultural competency? I would say yes to all of that. But let me actually address one piece. That's such a really wonderful set of interrogations there. I think on the one piece on the burnout, I think and I actually touch on this a little bit later, but I think that is what I really would say I learned from COVID was, I think I had some recognition of it, but it just like hit so deeply and painfully, was that worker justice issues and health equity are really, they have to be two sides of the same coin. And probably some of you have worked in nonprofits where they, in the nonprofit sector is, sort of rife with, well, one, white savior leadership, and then two, with this kind of martyrdom idea of that, well, you're just there to serve. And so, we're gonna sort of turn a blind eye about whether you're working weekends or working nights, or your kind of job stability or your benefit structure is not in keeping with true, like, with what 21st century worker rights should look like. And I think about it at Elmhurst. I should say also the context of that, the series of encounters with this individual at in the inpatient service at Elmhurst Hospital. We are this is September 2022, before this horrible flu and RSV season. The emergency room almost looks like it's during a surge in 2020. We have, because in large part because we don't have robust systems of home and community-based care and shelter placement, so people get stuck within our hospital walls. And we have a pretty severe nursing shortage. We have, I think, the burnout from among physicians is also very real. I could talk extensively about what we did to number of trainees, that class of interns who were interns, PGY, like postgraduate year ones in spring of 2020. I just think that they were so traumatized, and in many of the programs we just did not have the resources or leadership to give them time off, and it was done in often very times in discriminatory ways. But and at the worst part of the surge, we would have one respiratory therapist for 80 patients on mechanical ventilation, which normally maybe 6 or 8 would be more reasonable. So that those respiratory therapists were overworked and traumatized. Our whole system, with respect to physician burnout specifically, our whole system, really really kind of commodifies the what should be the healing art of medicine into something that drives physicians to want to make really ungodly amounts of money, and that I think also contributes to burnout, and it contributes to these power dynamics. And actually, I'll talk about that in a little bit. So we'll keep returning to that theme, but we'll move to the next slide. I forget where I am. Okay, so I wanted to talk a little bit about MPV, orthopox virus, monkeypox virus. So, this is in the health department. The health department. So on the left-hand side, you can see by race, ethnicity, and borough. You can see the light purple is the folks who were vaccine eligible early in the original vaccination distribution when we had the monkeypox outbreak. And then the dark purple is folks who actually received a dose. And you can see the arrows hopefully highlight this, that Black persons, folks in the Bronx, folks in Queens, folks in Staten Island, received vaccination disproportionately less than folks of other demographics. And the time series tells a similar story by race, ethnicity. This was coming out of we actually, so in the public health department, we activate an emergency response, and we'd actually been activated for COVID for about 2.5 years, and then it basically, that activation ended and monkeypox began. But a critical thing that we learned is that who lives, who dies, who gets vaccinated, who doesn't get vaccinated is so determined by structural inequities based on race, place, language, country of origin. And yet we made the same exact, very predictable mistakes. I mean, a big that we made as a health department in basically ensuring that folks of higher socioeconomic status were able to receive monkeypox vaccine earlier. There's a larger story about that, but you can go. And I think that there's programmatic of like, well, we started the vaccine in the Chelsea clinic as opposed to the Corona clinic. Like there's sort of aspects. The language we use was from the 1990s versus what the language is relevant in the early parts of the outbreak. So there's a lot that could be unpacked there. I think what I am actually really interested in is how in our actual culture as an agency, as a Department of Health, makes these kinds of errors predictable and happen over and over and over and over again. And so you can go to the next slide. And I want to say we have political, and there is no, we can't blame politicians here. We in the Public Health Administration, we have a pioneering resolution from the New York City Board of Health that says that we, the health department, need to address structural racism as a public health crisis. And this, and 9 months after this landmark resolution is passed, we saw the results of monkeypox. You can go to the next slide. So, I think that, and literally this came from a meeting with our commissioner, and I think it's we have a power issue. We have a power issue of how we relate to communities. If doctors try to control people's bodies rather than serve as consultants and advisors and accompaniers to their health and wellness journey. We do the same thing in public health with their communities. And we organize from a very top-down and kind of militarized approach to organizing institutions. This, you can go to the next slide. Oh, well, actually, let me pause there. I promised to pause on any slides that were purple. And any comments, critiques, questions in the chat or otherwise. Oh, let's see this. Oh yeah, so the question from Calvin, I'm going to interpret the your power. Well, I'm going to interpret it as the collective power of the agency, but I can also speak to my own administrative power as sort of a bureaucrat. Let me actually. So I think that let me say two things. One, I would say this is what I'm trying to get at is actually an internal cultural issue. You know, we can recommend certain vaccine policies, but ultimately, or masking policies, or COVID mitigation policies, or requests for investment from City Hall, but ultimately, City Hall and the mayor, will take that advice and do what they will with it. But what I am trying to get here is that actually those of us in positions of administrative power, like myself, have to really look at our own, like how do we actually organize as an institution, and how do we relate to our workforce? How do we relate to communities? And how do we make decisions? Because I would say in the monkeypox case, I think it's a great question. I think in the monkeypox case, I actually think that this was not, mayor, like us saying, well, let's do this, and the mayor saying, well, actually, we're going to do this. This was actually, I would say this was our internal decision making. But yeah, we'll go to the next slide because I think that starts to get at this. And I apologize for the horrible word art, but I put together, as part of my actual annual self-review for my boss, who's the chief medical officer, I had put together sort of this, trying to kind of accompany this, or sorry, trying to describe what I see as a dominant culture of management by control. And so I think if you click through just one at a time, it's a little overwhelming. So first of all, like, we do all of this stuff that basically, again, gets at this idea of like, we control, if you are a staff member, we use language like you're my staff, and we have this whole sort of posturing around, as if we're politicians, around, oh, well, my staff is going to do that, my staff's going to do this. And we really, the information flows is very top down. I mean, it's like kind of shocking if you come from outside into a public health arena, how kind of militarized our approach. It's not like we're not like running covert military operations. We're trying to get people vaccines. It's not. I don't think there's no real justification for our the sort of the power dynamics that we choose, but it does lead to a very disempowered and very poor experience for staff. You can go and click the next one. And I probably should have had this one click first, but it's sort of this dominant. It's driven by this kind of dominant management culture. You can click to the next one. And again, there's like some other concepts in there you can read and follow up. But it actually also, speaking of physician burnout, I think it also makes for a very negative experience for leaders, because in senior levels of governmental administrations, this also is true in somewhat nonprofit sector as well, but lesser so, there's often this kind of, this sort of churn of leadership of an administration changes, so you have a new person, or a person comes in and is kind of like comes in with sort of an academic or thought leader background, and they come in for a couple of years and then they leave. But I think one of the real challenges is that for leaders is that they become this gatekeeper and bottleneck, and it feels like they are getting squashed from above, of like whoever the political leadership is, and from below, the staff are discontent, or the staff are not taking ownership because they've been here for long enough to say, well, why should I take ownership over, or why should I solve my own problems? Because I know that any sort of problem solving that I try to do is going to get squashed by our hierarchical leadership. And then the next slide, you click through the next, which is just low program quality. So then we deliver poor services, and that demoralizes everybody. That reduces the amount of political will to invest in public health in this case. But again, this is sort of, this is very specific, I would say, to the New York City Health Department, but or at least my experience of the New York City Health Department, or my reflections. And but I think it's probably general. It's certainly general, I think, of many private and public bureaucracies. And then I do really believe that there's ways out of this. One problem, one challenge, one colleague, if you will, at a time. And you go to the next slide, and we kind of go through this quickly, but you can just click to the next one, where I do believe that there's ways in which we can get to a more self-actualized workforce, and there's a lot of things that we have to do at a structural level, which includes things like benefit, flexible work hours, career growth, and there are aspects of creating platforms for the folks who are kind of closest to the work to have their voice heard and recognized. You can go to the next button. A lot of that comes down to supportive management culture. I would say this is currently one of my own advocacy pushes at the health department, which is a new commissioner comes in, thinks they can solve things by moving boxes around on an org chart, and that what happened, one has to do that very judiciously. In a bureaucracy, your line manager has so much influence over your day-to-day experience, because we have especially in city government, we have a completely broken HR promotion process. If your line manager advocates for you, you can get closer to a living wage. Like, you can get better working conditions. You can have a greater scope of practice. You can be available for taking MPH courses or other kinds of professional opportunities. If your line manager is not supportive, you're really going to struggle. And the problem with senior administrators coming in and saying, "Oh, we're going to do a reorg because that will fix our problems," is that it's not humble with respect to the dynamic human system that bureaucracies are, and also not humble to the fact that when people change their line manager, there's a real trauma there, and you really lose some of that trust and championing of management vis-a-vis the workforce. You can go to the next slide, next button. And so then, I do think if line managers are more supported to see themselves not as controlling the workforce's bodies, but rather to be champion of resources and champion of work environment, and then you can have better programs, which is the next button. Or the wonky term, operational excellence. So I'm going to keep going. Just go to the next slide. So, back to COVID. So this is the, I think you all are probably fairly familiar at this point with which hospital you were admitted to in COVID really determine whether you survived or not, especially in that first wave. And you can go to the next slide. So now this is back to, and I think there was really, from our previous commissioner, there was a really wonderful just sort of framing of hospital never events, of pursuing aggressive debt collection, not paying healthcare workers a living wage, spending less on community benefit, because certainly in New York, all hospital systems are nonprofit, so they get enormous real estate and tax benefits. Delivering racially segregated care, such as happened dramatically in COVID, and then not being transparent on pricing. These are this is actually not specific to COVID, but these are the kinds of practices that made our hospitals, the workforce, and the care seekers so vulnerable to getting to dying during COVID, and to being harmed during COVID, and they're being harmed at baseline, irrespective of what pandemic is going on. And again, I think that this is built into our administrative power structures as organizations. So you go to the next slide. This was, I will admit, this was sort of an angry, because I come from the nonprofit sector, I read a lot of 990s, and I think a lot about the philanthropic industry. As I was an angry COVID doctor last year, I kind of looked into, who's profiteering off of people who are getting harmed by our healthcare system. And, and so I put together this table. This is just sort of a snapshot of the top 10 or so, not surprisingly, all of whom are men, almost all of whom are white men. And at a time where our healthcare system is fundamentally defined by inequities and care segregation by race, ethnicity, neighborhood, place of origin, language status. These folks are making millions and millions of dollars, and you could say, well, these are multi-billion-dollar enterprises. This is not, this is. But I think it erodes the culture. My thesis is that it erodes the culture of an institution, and it sets up incentives that go all the way down to the physician on the front line, who is now all they think about is RVUs, these whatever they like. Am I doing enough care? Am I bringing enough money? Or am I bringing enough grant money? If you're in the academic center, it creates such a toxicity that focuses less on impact, less on compassion, and more on the financial returns you're bringing to the institution. So I'm highlighting. You go to the next slide. I'm highlighting this as yet sort of another paradigm of the power issue we have in academic health centers that are supposed to be on the cutting edge of research, on the cutting edge of training, the cutting edge of care delivery, and I imagine some of you have been on some of the university anti-racism task force, but one of the challenges I think I've served on that at Mount Sinai, and I think one of the challenges is, yes, there are certain things that institutions will do around that are very positive around diversity in hiring, around creating more anti-racist work cultures. But when it comes down to the fundamental business model of how power is wielded within academic health center bureaucracies and by people like deans or professors or associate deans, or again, people like me, we duck the question. We duck the fundamental question, which is our business models all have very strong classist and racist consequences. So you can go to the next slide. This is my last slide, and I want to I want to be clear that I believe in evolution, in the evolution of human dynamic systems, and this is from a Detroit-based doula and activist whose book I highly recommend if you haven't read it yet. But that we have these systems. I'm not saying that that the doctor should go away, or Department of Health should go away, or Mount Sinai should go away. I'm saying that we have to evolve, and it's not strictly to tear down, but really to lift up and to identify ways forward that memorialize the harms and trauma that have happened. Again, whether it's during COVID or during other health crises or emergencies, or the slow and long toll of chronic diseases such as diabetes. But I really do believe that these institutions can change, and that they can change by us fighting from within and listening from those outside, and I think that's sort of again from my experiences in global health and the reforms that need to be taken there, to being a doctor, to being in public health administration, to being in an academic medical center. If we are able to lean into those aspects of power and how our power and baked into our various structures harms people, and then work to dismantle and untether and evolve those. So that's it. And I just curious to hear any reactions, reflections, critiques, etc.
Question.
Yes, we have a question from someone who's attending in person. Please go ahead.
Hi, so thanks for that presentation. I really appreciate that you talked about the environments in which people make these decisions and just the many different layers involved. Knowing that systemic change will always take a long time to happen, what are some strategies you've used to make sure that you are holding yourself accountable, at the very least at your individual level?
Oh, that's great. Yeah, thank you so much for that. Yeah, I mean, yeah, so I think that's it, and I think that's right. I think that there's the there's opening avenues to kind of some of the larger systemic reforms, and then I think especially in bureaucracies where precedent is so powerful, finding any avenue. So I will just say for myself, who came here very passionate about sort of worker issues, one of the ways in which I hold myself accountable is to be just very kind of vocal and persistent and empathetic. I think getting to know people in a dynamic human system is incredibly important. So I personally, and I've advocated in various ways on various structural reforms that we could make to decentralize certain centralized processes that are making for a very bad applicant experience and a very bad promotion experience, very bad salary adjustment experience for the workforce. Literally where it kind of goes through these 17 different steps, and there's no transparency or no visibility along the way, and we just say, oh well, that's how government works, and it's not like Moses wrote this down and told us government should work this way. And so so I think one is understanding the people, understanding the systems, having humility against that, and critiquing the system and loving the player every step of the way. And that also makes you a better advocate for when you're confronted with a specific case. So in my case, like I have specific situations where a specific person is being held back because of some inane rule that's not getting them a promotion or a salary adjustment. And so just I think for myself, just saying somebody has to sort of step up with a fancy title and just say, I'm going to keep at this until this issue gets resolved. And we can't take no for an answer. And it's not that you're the person in central HR or whatever is a horrible bureaucrat. I do think that the system has been set up over 2 centuries to punish the workforce and to be really bureaucratic and inane. But that's not that the individuals in those positions are really truly trying to do their best. And we're all kind of trapped in this larger system. So I would say the biggest thing I would say for me, holding myself accountable, is spending as much time listening to team members in the workforce, and then just whenever there is an advocacy opportunity for an individual. It's there's also the systemic stuff that I do a lot of as well, but like an individual setting that precedent of like, okay, well, I'll give you one concrete example. We have at the health department, we have a workforce that's employed by a nonprofit. So this was the nonprofit sector. They're kind of embedded, they're kind of seconded into the health department. This was set up about 20 years ago, basically as a way of getting around our kind of broken HR policies. And there's some real problems with it, but I think one of the things that I really took a lot of advocacy around was saying that, look, just because you're employed by the Fund for Public Health doesn't mean that you should have to abide by all the city rules. So the city has had a very long-standing rule against telework and against any sort of flexible schedules and hybrid work schedules and these sort of things. And for a lot of staff, that's really problematic. One of the things that we've been able to do is to make actual telework and hybrid work policies for the non-city staff, and to say to the city staff employers, look, this is what we're doing. And yes, it is inequitable. It's unfair, but if we get whatever we can take in terms of improving the work of the folks who are employed by the non-city partners, we can use that as leverage with whomever, City Hall, labor relations, et cetera, to then say, well, we can fight for the folks who are city employed. But I think it's very easy for people in my position to say, oh, well, it's not equitable, to use equity as this way of like ducking, of just like maintain the status quo, because the status quo helps only the people who are in sort of senior bureaucratic positions. And to say, actually, these are 2 different employers. This is one, a non-unionized, totally different benefit, no pension, really much minimal job security compared to the city workforce. There's nothing that's holding us back, and whatever the mayor says, it doesn't matter, because the mayor doesn't employ them, and then sort of pushing to say we're going to have that, and then using that as a lever to, which was it's a long-standing, it's going to be a long fight, but as an eventual lever in collective bargaining and other forms to say, let's have more blended hybrid work. And I would say, finally, whenever I mention hybrid work, I do want to acknowledge that we have to think of hybrid work from the perspective of folks who are able to work hybrid and those who are not, and I think that's really, and I would say this as a doctor at Elmhurst Hospital, I hope all of the people in IT and HR and anybody who's sort of helping to turn the lights on can work from home, because that helps. If that means that we can retain the best professionals to provide support to frontline workers, and especially frontline workers who are not making or barely making a living wage, how do we provide better working conditions, more flexible work hours for them as well, given that hybrid work is not an option? So I think that's that's a bit of that's one example, but I would say, I think it's something that to ask ourselves every day is like, what can I do for the person in front of me to help their life, because in addition to larger advocacy pushes.
All right, thank you. Thank you for that question. And we're right on time. So I would again like to thank Dr. Maru for joining us today and for really sharing such interesting work and insights from your work today with us. Thank you so much. And thanks to all the attendees. We'll be sending out information about the next seminars via email, so keep an eye out. And have a great day, everyone.
Thank you.
Thank you.
Thanks, everybody. Stay in touch. Thank you.